Cooper decided that today he's going to give us some information about the changes that the ACGME made in terms of resident evaluation, how we determine that they've achieved the level of training that they need to be advanced to their next level of training, or to be told that they can leave the program because they've achieved all their milestones. So, Paul, I'll let you take over.
All right. Can y'all hear me okay? All right. So this topic in general is not one that lends itself to a lot of cartoons or jokes or that kind of thing. So this is about the only one. Happy to report that I spent 50% more time in meetings this quarter. You could say conferences. This is not an accomplishment. Meetings are a complete waste of time. How would I have learned that without this meeting? So there's some things that we're going to talk about that aren't necessarily exciting, but they're very pertinent to your residency, both as residents and students and faculty. So the objectives are to be able to discuss the changes in accreditation for pediatric residencies, how staff will be able to, how staff and faculty will be able to understand the basics of the next accreditation system. Faculty will be able to incorporate the planning of their curriculum, no matter if they're talking to students, residents, fellows, other faculty, into the continuum of pediatric education. And then we'll be able to discuss the milestones as evaluations. No conflicts of interest. So just as some background and some basic information, so the ACGME is the Accreditation Council for Graduate Medical Education. NAS is the next accreditation system. So that's what we've moved into. I don't know what whenever they change it again, if it's going to be the next accreditation system. I don't really know what the old one was called except for just the accreditation system, but this is what we're in now, the NAS, the next accreditation system. So as some background, graduate medical education is a public trust, and the ACGME is accountable to the public. So kind of the way this started, and duty hours and all of the regulations that we have through the ACGME, all residency programs are funded through the federal government. Congress feels that since they're paying for it, they should have a say, and they do, but Congress regulates lots of different entities, truck drivers, airline pilots, lots of entities. They've allowed for residency programs to essentially govern themselves through the ACGME, but it's pressure from Congress and constituents that drive some of the changes that we have. So in order to keep Congress from coming in and making their own rules, ACGME has tried to stay ahead of the game and make changes so that Congress doesn't come in and do that. So ACGME was established in 1981. It doesn't seem quite that long ago for me, but the majority of residents now were not born when the ACGME was established. Major issues that were faced in 1981 were the emergence of formal subspecialty training and the variability and quality of resident training. All right, so for us, ACGME governs all residency programs. Within ACGME, each residency program has an RRC, which is the Residency Review Committee. And so we've got the RRC for Pediatrics. Now, the American Board of Pediatrics is a separate entity. American Academy of Pediatrics is a separate entity. But the RRC for Pediatrics, American Board of Pediatrics, and the AAP all work together. So ACGME is for residency programs, the RRC is for peds, American Board of Pediatrics is who gives you your board certification in pediatrics. And then the American Academy of Pediatrics works to get everybody together, as an organization. They can lobby Congress. They also they work with ACGME and the American Board of Pediatrics to help produce prep and to get you educated in the things that you need to know. All right. So again, variability in training and subspecialty training is why ACGME was established. So as far as the program structure, what they want to do with the NAS is increase the quality and quantity of formal teaching, balance between service and education, evaluation and feedback, financial and benefit support for trainees. So years ago, many, many years ago, residency was essentially an apprenticeship and you followed a doctor, and then it became residency programs, and so then it moved to ACGME and rules and program requirements, and so NAS is just kind of the next step for this. So efforts were successful, but program requirements became increasingly prescriptive, which then squelched innovation. So they made it so prescriptive that it didn't allow programs much wiggle room to find out what works for their program. And things that work for our program with 24 residents are going to be different than what works for a program that takes more than 24 residents a year. So some of the bigger programs take close to 40 residents a year. You know, so they've got 120 residents just for peds, and then they've got med peds and other combined programs that they have. So that's one of the things that the next accreditation system is trying to do. So they're trying to produce physicians for the 21st century, accredit programs based on outcomes, and reduce administrative burden of accreditation. So they want to allow good programs the freedom to innovate, assist poor programs to improve, realize the promise of outcomes, and we'll talk about that, provide public accountability for outcomes, and again, reduce the burden of accreditation. So how are they planning on reducing the burden of accreditation? So this standards will be looked at every 10 years. There's no PIF, so faculty know, but so this is what we would have to fill out every 3 to 5 years. Just a voluminous amount of material that we would have to collect. So instead of site visits, they're going to have a scheduled self-study every 10 years. Now, it's not going to be exactly every 10 years because they're not going to look at every single they're not going to look at all the programs in the country once every 10 years. They will look at every program every 10 years, but like probably our next self-study will be around 2017 or so. So they're staggering all of those. And then the site visits are, and then they will have some focused site visits if there are some issues that they determine, and we'll talk about that in a second. So essentially the PIF was just a biopsy of how the program was doing right then when they filled out all the information and when they came. So the move is they're going to start looking at more information annually. Not necessarily more information that was in the PIF, but lots of information annually. So they're going to look at milestones, which we'll talk about, the resident and faculty survey, and so that's why the resident and faculty survey is important, both for you to understand the questions, but also that's one of the things that they're going to be looking at as far as evaluating the program. Scholarly activity for both residents and faculty on a yearly basis, and then board pass rates. So this is the scholarly activity as performance indicator. And so each of y'all should have a handout. Faculty have this one. Residents have this one. And so I want you to just take a second. So in September, I have to turn in all, so I've got the faculty listed, all the residents are listed, and so I have to fill in for each of you this information. So if you will, And this is for July 2013 through June 2014. Okay? So if you'll just take a second, write your name at the top. If you know that you've published something, you can just indicate that. I can look that up in PubMed. Number of conference presentations. So this is, so there's two types of presentations. One is conference presentations. So these are abstracts, posters, presentations given at international or national or regional meetings. This is just a number. So if you know that you presented 2 posters at Southern Society's meeting, put down a 2. Other presentations are grand rounds, invited professorships, and that kind of thing. So if you're a faculty and you did a grand rounds this year, you can put that down. For the residents, if you gave grand rounds or presented at morning report, however many times approximately that you did that, and write that number down. It's in that teaching presentations. Okay? Faculty or residents, if you had a book chapter published within last year, write down how many book chapters, number of grants for which faculty member had a leadership role. So if you were a PI, co-PI, site director last year, write that down, and how many projects?
Grants include clinical trial agreements?
Yes, I would say yes. Leadership role, so if you are part of a national committee, as part of an organization that you're in through Pediatrics, you can put that down. I think that's just a yes or a no. And then formal courses. So if you were responsible for a seminar or a course, then you can write that down as well. Okay, and then for residents, if you had anything published, just let us know. National, so abstracts or posters at a national meeting or a regional meeting, textbook chapters, participated in research. So that's funded or non-funded basic science or clinical outcomes research last year. And then teaching presentations. And I think that everybody has had a teaching presentation as far as residents this year. So be sure and write your name on that and turn that in when you're finished. So instead of rules, corresponding questions, we answer the questions, then they come and visit, give you citations, and then they give us an accreditation decision. The next accreditation system is continuous outcomes. So the new institutional requirements, so used to all the program requirements were different for all the specialties and subspecialties. Now there are core requirements that are part of their institutional requirements that are part of all of the program requirements. So the majority of the program requirements now are maybe 75% are the same core requirements that are required for all residency programs. And then there's outcome and detail, which we'll talk about in a second. So there's, so as far as the institution is concerned, there's the institutional requirements, there's a self-study visit, and so the Graduate Medical Education Committee within LSU now has new requirements and new jobs. So they have to do an annual institution review, they have oversight of the annual program evaluation, and then special reviews for underperforming programs. Okay, and so the visit, the institutional visit that happens is a CLER visit, and that's a clinical learning environment review. All right, so they're going to look at 6 things when they come. They're going to look at patient safety, quality improvement, transitions in care, supervision, duty hour oversight and fatigue management, and professionalism. So patient safety, quality improvement, that's why that's important. That's why the, that's why we have a meeting every Friday for quality and morbidity and mortality. Transitions in care, so that's one of the things whenever Sarah and Dr. Habib were looking at devising a way for better handoffs. The requirement is that there is a handoff system. And so that's one of the things that I think that we probably need to do a better job with, and one of the things that's required and will be looked at our CLER visit. Supervision, I don't think that Pediatrics has as big of an issue as some of the programs have had in the past. There's always someone readily available by phone, and interns aren't here by themselves. Like in the in any situation within Pediatrics. Duty hours oversight. So this is a requirement by the ACGME. This is something that they look at, and so that's why that's why you have to turn in your duty hours every month. Okay, this isn't just something that we made up to try to be difficult. It's something that we have to turn in to the ACGME, and that they have to be able to see that we are looking at and taking account of. Fatigue management, Dr. David McCarty is going to come and do a grand rounds next month on fatigue and fatigue management, and that'll be for both residents and faculty, and then professionalism. So the things that they'll look at the resources, faculty, residents, measures, and improvement. So again, the goal, accredit programs based on outcomes, free good programs to innovate, provide public accountability for outcomes, produce physicians for the 21st century, and reduce the burden of accreditation. So how can programs innovate? Program requirements have been reclassified, like I said, to outcomes, core, and detail. So the outcomes are statements that specify expected, measurable, or observable attributes. So specific procedures that residents have to be able to perform, that's specific for pediatrics. Board pass rates, it's different for each specialty. Core requirements are statements that define structure, resource, or process elements essential to every graduate medical education program. So faculty qualifications, faculty have to be board certified. For us, continuity, ambulatory experience, major duty hour rules, overall resources needed for resident education. So programs that are good standing may freely innovate in the detail standards. So it's a statement that describes a specific structure or resource for achieving compliance with a core requirement. So some of the details, so we can change some of the specifics of our ambulatory continuity experience. So some places go out to private practice. I think that the system that we have is actually better than a lot of programs because you do get true continuity of care with your residents. Specific conference and didactic structure and electives that residents can choose. They don't say that everybody has to do a HEMONC rotation in residency. We've got some flexibility with that. So the self-study visit where they'll come and look at the program is still under development, scheduled every 10 years. Team of visitors, there's supposed to be minimal document preparation. They're going to interview residents, program directors, faculty, and leadership. So again, how's the burden reduced? Every 10 years, no PIFs, self-study, and focus site visits only for issues. So they're going to look at our annual program evaluations. So within graduate medical education, we have to have, they're looking at every program every year. And that's the APE, which I thought was interesting abbreviation. And interestingly enough, the institutional review subcommittee, which looks at all the programs, is the IRS. And I'm part of that, and it's just something that we have to do. But as part of the self-study, they want to learn future goals of the program and verify compliance with core requirements. All right, so milestones. So as part of the NAS, instead of looking at biopsies instead of coming and looking at the program every 3 to 5 years, the RCs are going to look at trends in annual data, milestones, resident and faculty survey, scholarly activity, board pass rates. So the milestones, we'll talk about the why, what, who, and when. So why are they looking at milestones? So the continuum of clinical professional development. So they are trying to move from just solely resident education to a continuum of education. So the continuum starts with the first 2 years with physical diagnosis, third year clerkship, fourth year sub-internship, or what we call as an acting internship, first year of residency, fellowship, attending practice. So what they want to try to move to is education that is more seamless and more of a continuum. So Ken Roberts talked about, there was an article recently that it was actually a talk that he gave about continuum. He said instead of thinking of clerkship followed by a lost year, which is the fourth year, followed by a separate 3 years, what if the clerkship director and residency director were able to think of having 5 years from the clerkship through residency? And I think that Dr. Broussard and I work well together. I think that we all work together as a group, but I think that we can do better as far as trying to integrate education from medical school through residency. And one of the things that he said that was interesting, so he was talking about, he was at UMass and was talking with the program director, Al Schneider, and he was saying, and so Al Schneider was he was the medical student clerkship director for Pediatrics. And he said, I happened to comment to Al one day that I was grateful he loved students as much as he obviously did. In our conversation, I shared that I loved residents and fellows more than medical students, and he asked how that was possible. I pointed out that only 13% of our medical students choose pediatrics for their career, so I had a failure rate of 87%. He then pinned me down. He said, what do you think that our job is? And he answered quickly that it was to teach pediatrics, and then he smiled, apparently having identified my error. He explained that our job was not to teach pediatrics, but to use pediatrics to help learners become the best doctors that they could be. And so I think that that's, you know, because we're going to have medical students who are third years, then fourth years who go into pediatrics but don't do residency with us. But that education isn't lost. It's all part of a continuum, and I think if we are all on board and are all moving in the same direction, that it's going to be better education for all doctors as well as for pediatricians. And so as part of the why, the move is from numbers to narratives. So the numerical systems produce range restrictions, whereas the narratives are more easily discerned by the faculty, and they're shown to produce data without so much range restriction. So the milestones are designed to help all residencies and fellowships produce highly competent physicians to meet the health and healthcare needs of the public. So the important purposes that they serve is that it allows continuous monitoring of programs, and I'll talk about the when in a second, public accountability, and community of practice for evaluation and research, with focus on continuous improvement for graduate medical education. So this is supposed to be a rich, descriptive developmental framework guide curriculum development of the residency or fellowship program, support better assessment practices, and then enhance opportunities for early identification for struggling residents and fellows. And for the residents, it's supposed to give a better explanation of the expectations or what we expect for you. Support better directed assessment and learning, better self-directed assessment and learning, and facilitate better feedback. So the what? So simply defined, a milestone is a significant point in development. And so for pediatrics, I think that we understand the milestones probably better than some of the other specialties. So the milestones are organized under the 6 domains of clinical competency. So we've talked about the 6 clinical competencies in the past. Observable steps on a continuum, describe the trajectory from neophyte to practitioner, intuitively known by experienced specialty educators. Provide framework and language to describe the progress, articulate shared understanding of expectations, and to set aspirational goals of excellence. So 6 competencies, we've talked about patient care, medical knowledge, practice-based learning and improvement, interpersonal communication skills, professionalism, and systems-based practice. All right, so the goals of the milestones is to, it permits the fruition of the promise of outcomes. All that means is that we're going to be looking at outcomes, the kind of resident and what they can do when they get out, as opposed to like just the competencies. We'll track what's important, use existing tools for observations. Clinical Competency Committee will look at the progress of each resident. It's essential for valid and reliable clinical evaluation system. And then the RRCs can track unidentified individuals' trajectories. And all that means is that they'll be able to see how the program's doing as far as the outcomes for the residents. So this is a sample of the worksheet that we fill out. So this is, and then let's talk about this and then we'll go back. So each of the, so this is the general competency. So this is systems-based practice. And so if you look at this sheet, okay, there are 21, it says milestones, but these are really sub-competencies. So the general competency is one of the 6. It's systems-based practice, okay? Incorporates cost awareness and risk-benefit analysis into patient care. So this, if you'll look, is not our number 2. This is another one. This is for another specialty. But so this is the sub-competency. So like for us, for systems-based practice, we have 3 sub-competencies within systems-based practice that are part of, those are 3 of the 21 total that you'll be evaluated on. Then these are the milestones. So each one of these is a milestone. All right? And so then each milestone is going to be evaluated. And as you can see, there are, even though there are 5 levels, 1, 2, 3, 4, 5, there are actually 9 blocks. So it's still essentially a 9-point system, so to speak. But this is someone who is approaching level 2 but may not have reached everything for level 2. So if it comes out there, then then the checkbox would be in the middle. And so the way I think about it is just like a Denver. All right, so for me, so these are the the 4 major domains of development, just like we've got the 6 competencies. Okay, and so then within within gross motor, you've got different things that kids can do. So if this is gross motor, and maybe you say this is locomotion, then this may be crawling, pulling up to stand and cruising, walking without assistance, running, climbing stairs. Okay? So you can see that it's a continuum. And the way that Pediatrics has done theirs is that the continuum is from a medical student to an attending who's been out in practice for years. So it hopes to do a couple of things. One, it shows you what the aspiration is, what you want to try as a resident and even as an attending, the goal as far as that subcompetency is concerned. So this is the milestone that everyone should be trying to reach. It also hopefully helps prevent everyone, so in their evaluations, hopefully prevents everyone from getting a 9. So the intern in the clinic who is, in their 2nd month of clinic, and they've got all 9s for all 6 of the competencies, doesn't really reflect where they are. And so this will hopefully give us a better way to evaluate the residents. And for most of the things, it's like you know exactly where that resident is as far as the milestones concerned. Some of them are wordy and a little bit esoteric, but I think that's just to give you the most amount of information that you can have. So 21 milestones, you've got those. So who's going to be doing the evaluation? 360-degree evaluations that we do. So faculty are going to evaluate residents. Your peers will evaluate you. Students evaluate you. Patients evaluate you. Nurses, and then other staff like case managers, respiratory therapists, those kind of ancillary staff. Then we're also going to look at in-training exam scores, continuity case logs, conference attendance, that's part of professionalism, monthly test scores, that's part of both medical knowledge and part of professionalism. The Clinical Competency Committee is created, and so there's a minimum of 3 members of the faculty that are part of that, and they put together, they essentially look at all of your evaluations and plug that into the milestones. When is this going to happen? So every 6 months, every resident will be evaluated on the 21 milestones. So they talk about decreasing the burden, but 21 subcompetencies, 24 residents, 504 check boxes per 6 months. So 1,008 check boxes for our program every year. So the program's with 120 residents, and it may not be. I think that the amount of work stays about the same. You just have to do not quite as much whenever you as far as the old site visits and that kind of thing, trying to get the PIF together and all that kind of thing. All right. So what we're going to do is so if you look at this worksheet. So this is patient care. These are the first 2 milestones in patient care. And you can see that the amount of information, it's a lot to read, especially every time. And so I'm not going to have every evaluation have 21 of the subcompetencies on it for you to have to fill out. Okay? there's a fair amount of overlap. Some don't correlate as well, inpatient versus outpatient. And so essentially I'm cutting that in half as far as the evaluations are concerned. So instead of 6 questions that y'all have had every rotation or every resident to evaluate, it'll be about 10. Now, the other thing, there's luckily the pediatric program directors share pretty well and get along well together, and so we've all kind of borrowed different ideas, and so I've put together, if you look at this is a condensed version of this. So as you can see, a level 1, so talking about gathers essential and accurate information about the patient. So a level 1, so this is medical school level. Either gathers too little information or exhaustively gathers information following a template regardless of the patient's chief complaint, with each piece of information gathered seemingly as important as the next. Recalls clinical information in the order elicited with the ability to gather, filter, prioritize, and connect pieces of information, being limited by and dependent upon analytic reasoning through basic pathophysiology alone. Okay, so you know that medical student, okay, who gathers all this information, they will have a hard time prioritizing it. This is the shortened version of that. Gathers too much or too little information or the same information regardless of patient complaint, unable to filter and prioritize when presenting. So, so what the evaluations will look like, it'll be the shortened version. I'm going to give all the faculty members and the residents the long version so that they can see exactly, residents can see what they need to be doing, where they should be as far as their level, what they can aspire to as far as what the ultimate goal is for that competency. But as far as, I think that the abbreviated version gives the attendings all the information that they need, and it'll help things move more quickly as far as evaluating. The first few months of evaluation are going to be more time consuming because you're getting used to the milestones. But I think that it's going to be, I think it'll go quicker and quicker as we get used to them and get used to the verbiage. Any questions about that? And so the ultimate goal is to, so for each resident to be able to say, so level 3 and level 4 is where residents should be whenever they're graduating. Mainly level 3, some will attain level 4, especially like professionalism, and there'll be a number of stellar residents that'll achieve level 4 in some areas. And that's also kind of where fellows should be, whenever they're finishing fellowship and that kind of thing. But as you can see, there was talk about the milestones. Well, once they've reached the milestone or a certain level, then could you say that they were finished with residency? Or if a resident hadn't reached a certain level, are they going to need to do an extra year, which would create all kinds of problems. But as you can see, especially with the pediatric milestones, it's a continuum, with the last stage being an attending who's been out in practice for a number of years. So that's the goal for the residents, to reach that level 5, but you don't have to reach level 5 to finish residency. And then the next thing that they have, that you'll probably see in the literature, but but they haven't really decided exactly what they're going to do with, are the Entrustable professional activities. So when I'm doing the PowerPoint and you're in edit mode, Entrustable comes up with a red line underneath it, because it's not recognized, because it's not a real word. It's a word that they made up to try to describe this. So the EPAs are units of professional practice defined as tasks or responsibilities to be entrusted to the unsupervised execution by a trainee once he or she has attained sufficient specific competence. So what they're trying to do, so they've talked about how trust is a central concept in healthcare. So public needs to be able to trust that when we say a resident's ready to practice independently, they're ready to practice independently. So the public trusts us to be able to say that, that this resident is competent. And then in teaching settings, supervisors decide when and for what tasks they can entrust trainees to assume clinical responsibilities. So as far as how do EPAs differ from competencies, the EPAs aren't an alternative to the competencies, but it's a means to translate the competencies into clinical practice. So competencies are descriptors of physicians. The EPAs are descriptors of work. And so I'll show you something in just a second. EPAs usually require multiple competencies in an integrative, holistic nature. So what they're talking about is, so executing a patient handover. So so these are the EPAs, these are the 6 competencies. So being able to provide a good patient handover is more than just one competency. It covers a number of different competencies, and and for a lot of things, professionalism is almost part of everything. But as far as kind of drilling down and seeing what's important, you have to have knowledge about the patient. You have to have knowledge about things that might happen, which also dovetails into patient care, intercommunication skills, and interpersonal communication skills. So being able to relay that information, being able to talk with your fellow peers and with faculty, systems-based practice, talking about using the system as a whole. So being able to use the case managers, being able to talk about, well, we need a neurology consult on this patient. This patient is kind of getting ready for discharge. We need to talk to case management, talk about home health for IV antibiotics, and that kind of thing. So the EPAs incorporate multiple competencies. And so what they're trying to move toward is where the entrustable, they're trying to define entrustable professional activities for each specialty. But they don't have all of those divvied out yet. One of the articles that I read said that they go into the milestones and the next accreditation system, and then EPAs and all that is kind of like trying to build an airplane mid-flight. They don't have everything, they don't have all the answers for this or how it's all going to work, but outcomes is what the ACGME is moving toward, and so that's why all residency programs are now required to do this and are part of the next accreditation system. So again, the goals for NAS: accredit programs based on outcomes, free good programs to innovate, provide public accountability for outcomes, produce physicians for the 21st century, and reduce the burden of accreditation. Here's some of my references. The single biggest problem in communication is the illusion that it has taken place. So hopefully some of this is sinking in, and this is going to be a learning process. It's a learning process for all residency programs, and so if you'll bear with me and Dr. Love and Dr. Habib as far as whenever we're trying to give you the information that we get as far as evaluations and the next accreditation system. Any questions?
Well, I imagine for the students, like everything else, the ACGME has made changes. They eventually filter down into the medical school years, and so junior and senior students are often then fit into the same patterns of evaluation. So I would expect that this is not only going to be promulgated here, but over time work its way down to medical student evaluations as well. So as faculty then evaluate, there will be modification of all of the evaluation forms on a monthly, for the monthly evaluation, so that all of that will change as well.
Right.
So that all fits in with what we do.
Right. So Dr. Bocchini's asking if the evaluation, the monthly evaluation will change, and they will. So we'll move to evaluating residents based on the milestones, which are part of the competencies. So we're still doing competencies, but the milestones are just ways to better evaluate where the resident is. So instead of just evaluating that they on a 1 to 9 scale for practice-based learning and improvement, we'll be evaluating how they're gathering essential and accurate information. For patient care, gathering information, essential and accurate information about the patient. So instead of just giving them a patient care, they were an 8, this month in patient care, this gives you, so like for patient care, there are 5 different sub-competencies, and so residents will be evaluated. But they won't be, so everyone won't give, so like for the clinic, provide transfer of care that ensures seamless transitions. So we'll evaluate that on the ward, in the PICU, in the NICU, because that's not as important in the clinic. So the clinic won't have to, so everyone's not going to have to evaluate the 21 competencies or sub-competencies. It'll be about 10 per evaluation. So they will be evaluated using their own form.
And they all have their own form, which we already do. I mean, anesthesias is different than family medicine, which is different than ours.
And part of it is part of the reason why we're doing this, so there are some, so like the patient evaluations aren't going to necessarily be exact, they're not going to be exact wording of these, but we'll then correlate what those questions are to a sub-competency. So that then hopefully at every 6 months, we'll run a report and it'll give us an average for each of the sub-competencies. We'll look at it. If it looks like they're in about where they should be, then we'll click the correct check boxes and send it to the ACGME. If there are issues, then it also gives us a better idea of, they're great in professionalism, but they're having an issue in this sub-competency, with patient care. So I think it'll actually should help with some remediation if we need to do that. Lady, much time. You want to? Yeah.